All right, back by popular demand, I'm going to just introduce Alex Moore again. A couple of weeks ago, we did a tutorial on dermatologic, neurologic, and ophthalmic manifestations of systemic disease. And we had a lot of inquiries about more detail for all of them. Really, we didn't give it any of those topics enough time. So I would like to introduce or reintroduce Dr. Alex Moore, who is a dermatology registrar, just finished her residency and is looking at sitting exams next year. And she's going to be doing some consulting with the Vets North, telemedicine consulting, and can review dermatology cases and provide some input on the cases, essentially. So Alex has agreed to go through a little bit more detail on derm manifestations of systemic disease, and I'll be learning alongside you guys. So go for it, Alex.
Thanks, Anna. All right. So as Anna said, there's lots of things to cover here. I have just chosen to focus on three main conditions today. There are plenty other diseases that if there's interest, I'm more than happy to do a follow-up lecture on that. But for today, we'll be talking about paraneoplastic, zinc, and then drug reactions.
My captions didn't quite get paraneoplastic.
Oh, it's too complex.
Yes.
All right. So for today, I guess what I really wanted to focus on is that these clinical signs that the skin can express should be clues. So when you're looking at a case and you're thinking, it doesn't just quite look like, an allergic dog or cat. Maybe there's been a poor response to what you've tried so far. So corticosteroids, or say you've had the animal on antibiotics, you've cleared the infection, but it just doesn't look quite right. There's some clues that the skin can give us as to an explanation as to why that might be. So it's not, it might be something more than just skin deep. And then the other thing I wanted to mention is that dermatologists are often referred these cases, but ultimately, because they are systemic underlying diseases, we do need often the help of internists and surgeons, and sometimes even these animals are presented to ECC. So it does become a bit of a multidisciplinary approach. So for paraneoplastic cutaneous syndromes, we're just going to focus on cats today. This is a dermatosis that is secondary to some sort of underlying cancer that does not involve the skin. And so the skin signs normally develop after the malignancy, but they can also run as a parallel course. And then the two we're going to be talking about are paraneoplastic alopecia and then exfoliative dermatitis and thymoma. So for paraneoplastic alopecia, I'm just going to move maybe that there. Is that better? So then we're not blocking the photos.
Yeah.
So paraneoplastic alopecia, this syndrome is unique to cats. So it hasn't actually been described in dogs and thankfully also not in people yet. It is always associated with some sort of internal malignancy, and overall it is quite rare. And so the cancer of origin is most commonly a pancreatic carcinoma or adenocarcinoma. However, there's often hepatic involvement, so a hepatocellular cancer. And there has been a few reports I found of metastatic intestinal carcinoma, but not as common, I think. Pancreatic cancer should sort of be at the top of the list and where you want to start investigating first. This journal was really interesting and cool for anyone who's interested. It was about a cat who had a pancreatic and a hepatosplenic plasma cell tumor, and it's out of VetDerm, as you can see, in 2016. It's got some nice pictures as well.
Can I just jump in? I actually had a case last week with a cat that had multiple nodules that looked like metastatic neoplastic process on ultrasound, so renal, pancreatic, liver, and spleen. And we aspirated it and came back plasma cells, and this cat's globulin was 92, like really elevated. So it's a multiple myeloma cat, and I couldn't actually find a case report of multiple myeloma or plasma cell tumors in the pancreas, but there it is.
Yeah, there you go.
Yeah.
And sorry, did that cat have any cutaneous signs, or was it all? metastatic
Didn't that I
internal.
noticed, but it was clipped when I arrived for ultrasound. So I may not have noticed if I had, because the distribution of the alopecia is usually quite ventral. So they probably actually clipped it beforehand.
Mm,
Sorry to interrupt. That's really interesting. I'm going to read that one.
yeah, that's really cool. There you
Mm.
go. So with the paraneoplastic alopecia, I guess even if that cat was clipped, it's quite characteristic in how it appears. And just going back to that clue idea, this should be something that's at the forefront of your mind if the cat comes in looking like this. So these two photos show alopecia, normally ventrally, as Anna said. So it starts with hair falling out on the ventrum, sort of in clumps, and then moves to the limbs. And then the skin that's underneath gets this really shiny, sort of glistening, like sweaty almost appearance. And this is basically pathognomonic for this paraneoplastic alopecia of cats. And so you can see sort of here, the photo's a little bit dull, but it's got a bit of a shine to it. And then here on this forelimb, you can see even on the pads there, it's pretty obvious. Another characteristic feature is this sort of crusting or pododermatitis. And so the cats will get not only this alopecia, but they'll get hyperkeratosis of the paw pads, which is not something we commonly see. So that's sort of focal there. In cats, it's more of a dog thing as they get older and they change their weight bearing or associated with hypothyroidism. But in cats, it's a little bit of a red flag. And then they'll also have this brown sort of greasy keratosebaceous debris interdigitally and also around the claw folds. So there's two kind of obvious things there to look for. And then again, you have this shiny, glistening skin, a progressive ventral alopecia. So it does eventually, in really chronic cases, also spread to the dorsum. But normally there's sort of crappy tufts of or clumps of fur on the head and on the pinna and the face. So they're spared. And then the hair coat is obviously of very poor quality. And there's erythema, scale, and crest. And then cats are over grooming. So these cats can present, I guess, as an allergic cat. And so often they'll go down that route of being worked up for food or environmental. But typically, allergic cats don't have that shiny appearance. And then I guess the other thing, just going back to this, I wanted to mention that it is usually older cats, but there have been a few case reports I saw affecting cats who are as young as 4, which is really sad. But normally it'll be 10 or older. No age, no, sorry, sex or breed predisposition though. And so just focusing on this keratosebaceous debris that they get, Malassezia dermatitis is another hallmark for paraneoplastic syndromes in cats. And so cats can have Malassezia dermatitis secondary to allergies and other sorts of dermatoses, but when it's in conjunction with the other signs we just spoke about, paraneoplastic with Malassezia should be sort of coming to mind. And it's itchy as well. So the way we go about diagnosing paraneoplastic alopecia is via advanced imaging. So that could be ultrasonography, radiographs. I don't know, and I'm probably not going to cut it. You're going to want CT or ultrasound, I would have thought, to go looking for that pancreatic hepatocellular mass. And then you can do an XLAP, for FNA, sort of biopsy of the tumor. But normally, if you have a mass there, and you could do histopath of the skin together with your signement, your clinical signs. That's pretty much enough to get the diagnosis. Interestingly, if caught early enough, a surgeon can resect the tumor and the derm clinical signs will resolve. But unfortunately, if there are metastatic lesions speckled throughout the intestine or elsewhere internally, then the derm signs are going to relapse as soon as those little baby tumors sort of start to grow again. And so overall, the prognosis isn't great, unfortunately. Sometimes because these cats have sort of been bounced around, worked up for allergies, treating infection, that kind of thing. And by the time we think paraneoplastic, the tumor's already probably not able to be resected. But quality of life, keep the cat comfortable, treat the secondary Malassezia for sure, again, because they're super paritic, these cats, and that sort of contributes to that ongoing progressive alopecia as they overgroom. But recurrence is quite feasible, unfortunately. And then just a few more case reports. Some of them are a little bit old, but still relevant and quite interesting. So it is rare, but when you go looking, there are certainly enough cases out there.
Yeah.
All right.
Whilst it's rare, it is it's something I probably see about once a year, I think.
Mm-hmm.
But I guess that my caseload, I'm doing a lot of ultrasounds in animals that aren't eating very well. And it's like when you're actually sort of doing the ultrasound, you sort of say, oh, there's a pancreatic mass and alopecia under the arms or ventrally. And it is
Yeah, for sure.
because it can be really hard to identify pancreatic neoplasia. And you know you need to look really hard if that alopecia is there.
Yeah, true. And maybe that's when your skin biopsy also comes into play, I guess. I've only seen a handful of cases as well in my time. And we did end up sort of doing both. While the cat was anesthetized, we just took some quick punch biopsies after the radiologist was finished her part. And then you've kind of got those two bits of information, I guess, to put together.
Is the histo very distinctive? Like if you don't
it mainly rules out, I guess, I think in this section I talk about differentials, but if you look at this cat, epitheliotropic lymphoma and sort of diabetes or hypercortisolism would be at the top of the list, also dermatophytosis. And so I wouldn't say it's super characteristic, the histopath, but it does exclude your other most likely differentials. Okay, so we don't really know too much about this in terms of the pathogenesis for the exfoliative dermatitis with thymoma, but it is suspected to be an immune-mediated T-cell driven process. And that's because in the histopath from these cats, there is a predominance of CD3 T lymphocytes. And also from what they know, I guess, with humans and sort of T-cell driven processes, there are some similarities. With this one, interestingly, the cutaneous signs will normally precede the systemic signs. So because it's normally a thymoma, there'll be sort of respiratory, coughing, dyspnea, weight loss, anorexia, etc. But unlike the paraneoplastic alopecia, where those two sort of derm and systemic signs can run their course together, in this case, the cat will start to look physically different before perhaps it starts coughing. And then again, there's always an association with the thoracic mediastinal mass. And so the clues that we're thinking about when we see a cat, again, normally older, but there are some red herrings. Older cats who come in, they've got this really characteristic marked diffuse scale. So the scale sort of peels off in large sheets, and that's quite, abnormal. Not much else does that. There's crusting, but I did 3 pluses for scale and 1 plus for crust to reflect which is more sort of common. Patchy alopecia, of course, generalized erythroderma. They look a bit hyperthyroid, as you can see. They're not grooming anymore. And there's really not much pruritus, again, compared to the overgrooming we see with that paraneoplastic alopecia, unless there's a secondary infection, which is also relatively common with these cats as well. So they get a similar malassezia dermatitis, normally around perioral region, periocular, ears, and on the claws, so paronychia, and they can also have a secondary pyoderma. So I wrote pruritus with a question mark there to make you sort of think, okay, well, this cat's itchy, then it can't be exfoliative dermatitis, but secondary infection complicates and confuses everything. So again, sort of the main differentials would be cutaneous lymphoma, hypothyroidism, dermatophytosis, and less commonly, but I put EM on the list as well. Multiple other tests you could do to rule that out. But again, advanced imaging and histopath are going to give you your pinpoint diagnosis. This was interesting. I found that I think overall, the thymoma cases tend to carry a much better prognosis than, say, your pancreatic paraneoplastic alopecia. And that's because if they are caught and removed surgically, there's a stat that says there's a 3-year survival rate of 74%, which is not bad. And there's some reports of radiation, but I think generally speaking, most cases are just straight to the surgeon. All right, moving on to the next part. So zinc responsive dermatitis. Before we sort of get into that, I just wanted to mention the main functions of zinc, because I think we all know it's good for, immune system and overall skin health, but what does that actually mean? So it's an important enzyme cofactor for our DNA and our RNA, protein metabolism, fatty acid biosynthesis, vitamin A metabolism, immune function. It's anti-inflammatory, and it just contributes to overall skin and hair coat health. And so if dogs and cats don't have enough zinc, then we're going to see a reduced epidermal turnover. So that means not only poor skin and hair coat condition, but they get marked diffuse scale or dandruff down the back, and then debris builds up as well because those skin cells aren't turning over as readily as they should. The hair can become depigmented. There's reduced immune function, and so we see an increased susceptibility to infection and delayed or impaired wound healing. And then this was kind of cool. The systemic consequences of having a zinc deficiency can include a reduced sense of smell and taste, which I didn't actually know the correct medical terms for them, but there they are. I won't attempt to pronounce them.
Come on.
Hyposmia.
Yeah, surely.
That one was all right.
Yeah.
Oh, I don't know. How do you say the next one?
Do you reckon it's juicier or goosier?
I don't know. They both sound pretty bad.
It's a bad side effect.
Anyway. Alrighty, so there's two clinical syndromes that we see in dogs with zinc-responsive dermatitis. The first is the one we're going to focus on, Syndrome 1. So this is a familial zinc-responsive dermatitis of huskies, malamutes, and samoyeds. And then Syndrome 2, which we won't touch on today, is associated with young, rapidly growing puppies who are just fed a really poor diet, basically. And I don't think we probably see Syndrome 2 much anymore, considering the world we live in today. There's lots of great high quality dog foods on the market. And so this might be something that's probably fading out. So for Syndrome 1, it's a genetic defect, and these dogs have a defective intestinal absorption of zinc. The affected dogs are fed a complete and balanced diet. So again, that differs to Syndrome 2. And the clinical signs will appear in early adulthood. So when these dogs are still young, and they can worsen during times of physiological stress. So that means if there's systemic illness or if there's infection, or also estrus, I read, can make everything look a little bit worse. And so the signs we see in these northern breeds who have zinc-responsive dermatitis, the main thing that comes to mind is this hyperkeratosis, and it's normally over pressure points. So a husky will walk through the door and it will have really extensive alopecia and crust, normally over, say, their elbows or the hocks. You can also see it around the mouth and around the eyes. And the hair coat's really poor. So it's dull, it's flaky, there's that dandruff because our epidermal cells aren't turning over properly, but they're also greasy at the same time. So it's a little bit confusing. They're dry but greasy. And that's because they're also seborrheic. And there's regional pruritus. So that means that they're pruritic in those areas that are affected, but not generally itchy where the skin and hair coat is unaffected. Secondary pyoderma is also quite common with these cases. So again, throw that in the mix and it just confuses everything. So zinc-responsive dermatitis is cool because once you diagnose it based on histopathology, skin biopsy, it is treatable, but because it's a genetic defect, treatment is obviously going to be lifelong. You can taper the dose and the frequency of the zinc supplementation. So it doesn't mean that what you start them on day one, once they're diagnosed, is what they have to be on that dose for the rest of their life. And so you sort of gauge it based on, the clinical response, how they're looking, how they're feeling, what the pruritus score is. And so you can supplement them with zinc, elemental zinc ideally, but you can use other ones I've listed down here, down the bottom, usually at a starting dose rate of 2 to 3 mg per kg per day, and always given with food because it's absorbed better with a full meal, and also less chance of gut irritation. So vomiting, diarrhea, and nausea seem to be the main side effects. And I think that's the same for people taking zinc as well. They say to have it with a full meal.
Mm-hmm.
Interestingly, corticosteroids, sort of a low dose anti-inflammatory, 0.5 to 1 mg per kg can be used initially. And what that does is help manage the pruritus, make the dog feel better, but it also helps to increase the zinc absorption in the small intestine, which I thought was kind of cool. So it's not forever, but you could start a short course of pred, maybe 2 to 4 weeks, something like that, and then wean off based on response to treatment. And then omega-3 and 6 fatty acids also help to improve the hair coat, reduce the inflammation, things like that. So omega-3 is obviously your high-dose fish oils, and then your omega-6 often will supplement with, I like to use evening primrose oil because you can buy capsules that have actually both in one. So it's nice and easy for the owner. They're not sort of juggling, pred and zinc and then omega-3s, omega-6s, and all of a sudden the dog's got a bigger pharmacy than the owner. So multimodal sort of treatment is always useful. And then topical therapy, we love that in derm. So I included a photo of this shampoo. It's called Sebazol. I like it for these seborrheic sort of crusty dogs because it has a keratolytic and a keratoplastic, meaning those substances that break up keratin. And so if you shampoo that and leave it on the skin and the hair coat for a good 10 minutes, it does kind of loosen all that crust. And often that's where the infection is. So it also has an antiseptic and an antifungal topical agent in there as well. So that would be something to think about having the owner doing. Again, it's a northern breed dog, so it's not going to be a fun job, but the benefit would be great if they can shampoo the dog once to twice a week. All right, then just our last topic. So drug reactions.
I was just going to ask what the kind of frequency of zinc responsive dermatosis is in Australian bred northern breed dogs. Do we see it often?
I don't think so. At least in Perth, I saw one case in 4 years, if that's any help. East Coast might be exactly in a referral setting. East Coast might be different. However, when I was in America, California for 3 months, there were 2 cases in the space of 3 months. So yeah, you're right. Maybe it's a poor breeding.
We quite often read about these sort of syndromes that relate to genetic pools overseas, and like the incidence of like IMHA in Australia is quite different breed wise than it is in North America, sort of thing. So yeah, I'm just interested in that distribution.
Yeah.
And what in the diets that are deficient in zinc, so if it's a type 2 or the secondary zinc deficiency, what do we normally see, like what is a diet deficient in macronutrient wise? Is it meat or?
Good question. I'm not overly sure, to be honest, but I guess when I was reading about it, I sort of thought, puppies who are fed maybe Weet-Bix and scrambled eggs sort of thing, just not a complete diet. And then what also came to mind is I've spent a bit of time in, India and Bali, and you see those poor street dogs that are just skin and bones, and maybe they're the cases as well, where they sort of eat once every 3 days, whatever they can. But yeah, I'm not overly sure. I guess that kind of feeds into the whole, should dogs be fed a raw diet debacle, which is a whole nother conversation.
It's a huge conversation, which we're very open to. We've done a few tutorials where we've been quite opinionated on that. But just Googling, zinc is like all meats and seafood are rich in zinc. So it would be a diet that's deficient in meat. So like you say, like Weet-Bix and scrambled eggs kind of thing, that is most likely to trigger a deficiency. So those puppies, they're the Weet-Bix puppies.
Yeah, okay. And then again, I was just thinking sort of developing countries where, rice and grain and tofu is sort of fed to a lot of dogs over there. Again, socioeconomic issues, humans have to eat before the pets, and maybe they're not able to have enough meat. So yeah, it'd be interesting the distribution, I guess, or the geographic differences we would see in dogs over there versus in, Australia.
It's going to be interesting as whole food diets become more commercially available, but not necessarily better researched, whether we're going to see an increased incidence of this because there's lower quality protein being included, like soy protein or something like that, rather than meat protein in those diets. The whole food doesn't necessarily mean rich in high quality ingredients. Yeah,
definitely. And I think getting a little bit off topic here, but I do think that at least for the derm-specific diets, when you're looking at, say, doing novel proteins for diet trials, the Australian market is really hard to crack. So there's lots of different, some good, some bad, novel protein diets available in the States. But then trying to get them imported into Australia is a whole thing because some of them are not as nutritionally balanced as they should be. And then there's all these sort of legal issues. So I think Australia does have quite maybe a tight market in terms of what can be sold.
Yeah.
And so maybe that's, again,
it doesn't
another
feel
thing.
very regulated from the inside. Like maybe importing is regulated and the rest isn't. But...
Potentially. Yeah.
Anyway, off topic.
Cool.
Sorry to take you on a tangent.
And then last time when we did our segment, there was some interest in drug reactions, which, to be honest, is quite a difficult topic to research and present. And that is because drug reactions can really look like anything. And so they can be really challenging to diagnose. So a cutaneous adverse drug reaction is an adverse drug reaction that primarily affects the skin. It's also known as drug eruption or drug allergy if you're reading into it. There's some other terms that are interchanged, but CADR is the most sort of commonly accepted term for this. Uncommon in vet med seems to come up in a lot of literature, but then I guess you have to think, well, are the cases actually being reported by vets? Because if we don't know what we're looking for, maybe that will affect the incidence of the cases that are appearing in the literature. So, for example, when we get into this in a little bit, but there are some drugs that we give that we know are going to produce side effects, and we sort of not accept it, but we know what's going to happen. So, for example, PRED, you get your PU, PD, PP, you get your dermal atrophy, and worst case, you get calcinosis cutis. But is that a drug reaction, or is that something we just expect to happen? So there's a bit of a fine line. It's a little bit controversial in terms of what people think is a true drug reaction and what's acceptable. And then so that sort of feeds into this. So you can have an immunological or a non-immunological or predictable or unpredictable drug interaction. So what we're talking about is the non-immunological. So that means a non-dose related effect that the drug has on that individual. And why is that? We don't really know in dogs and cats, but in people, there are individuals who are more susceptible to drug reactions based on their genetics. If they've had or have some sort of viral infection that interacts with the immune system at a really high complex level, and then the drug gets involved and upsets the balance as well. Drug history. So there was some information that suggested if you're potentially a hypochondriac or someone who has, many diseases and does have to take a lot of medications, that exposure to lots of drugs over time could then potentially set you up for having a drug reaction. And then atopic individuals similarly are also somewhat predisposed, which I think would make sense. Having sort of that overreactive, constantly overstimulated immune system, if you're allergic, does sort of lead into potentially being more reactive to everyday substances. And then most commonly, it's a type 1 IgE mediated or a delayed hypersensitivity reaction. But again, this is mostly based off human literature, and we're still learning about this for our veterinary patients. So again, any drug, literally any drug, can cause a drug reaction. It can be oral, topical, inhaled, or injected. Some common culprits, which we've probably all heard about, probably all used in day-to-day veterinary practice. Sulfonamide, so TMS would be something. Probably as dermatologists, we do reach for quite a bit based on the rise of the MRSP. Penicillins, not so much for me personally, but maybe your largies vets. Cephalosporins, everyday use, and then any kind of topical agent as well. So I have seen quite a few reactions to chlorhexidine, 2% chlorhexidine. It's not always so innocent. This was really cool. This was presented at the World Congress, and we won't go into it in too much detail, but on the left here, you can see the dermatological clinical signs and or diseases, and then sort of what drug commonly can induce those. So that's a good reference. And then again, so drug reactions can mimic any kind of dermatoses, But most commonly in dogs, we see a contact dermatitis. So thinking about where maybe that topical product was applied, exfoliative dermatitis, so that sort of dry, scaly appearance, and then pruritus causing marked self-trauma, so excoriations and alopecia, etc. And then your maculopapular eruption as well. And so that sort of leads into, again, this would be another lecture in itself, but EM, sweets, or neutrophilic dermatitis, and wells, or eosinophilic dermatitis, drug-induced pemphigus foliaceus, and then vasculitis. So these are disease entities in themselves based on what we know how to classify them in terms of human literature that can certainly be drug induced. So there is some thought about them, but again, they're sort of their own separate entity. And what I mean when I say that is they always present the same way, and there's characteristic features on histopath that are used to diagnose these things. Whereas often we end up with a diagnosis of drug reaction, but we don't always know what drug or what topical agent caused it. And then in our cats, we see contact dermatitis and then pruritus causing self-trauma. And cats, even allergic cats, we can see how much damage they can do to themselves when they're that pruritic.
Alex, I'm sure this is really obvious, but maculopapular, is that what that says?
Yep.
Explain what that means. Sorry.
Yep. So macules are flat, erythemic sort of lesions. So we differentiate that from a plaque, which is raised. And then your papules, you can have pustules and papules. So papules, think of like a small little raised pimply type lesion. And then your pustules are pretty much the exact same, but 3 times the size.
Right.
So maculopapular means your flat erythemic macules or spots sort of coalescing into raised pimply type lesions.
Thanks.
Yep. All good. And then I just included this case because I think it's really cool. I saw this in California. It's a white fluffy of some kind, and this poor dog actually has erythema multiforme, so EM. And this dog had unfortunately, lots of different oral antibiotics, topical chlorhexidines. It had been vaccinated recently. Like it had everything under the sun in the last 6 months. That we know that EM is normally drug induced, but this just sort of is a good example as to it's EM, it's drug induced. We don't know what caused it, and we probably never will. Unfortunately, this is quite a severe case of EM, and this dog was covered in these raised, crusted, sort of annular serpiginous plaques. And so I think we ended up euthanizing him, unfortunately.
Oh.
But yeah, EM, it's not a nice disease, but it doesn't have to be that bad if it's focal and caught early. But again, drug induced, so relevant.
Wow.
And then I just wanted to highlight some of the breed predispositions that we think about. And so schnauzers can get a really awful necrolytic, superficial necrotizing dermatitis, and it's normally associated with some sort of insecticide topical shampoo. And so we're always cautious as to what sort of topical products we prescribe to miniature schnauzers in particular. So there's a genetic defect there. Normally, most of them are fine with your standard sort of chlorhexidine type thing, but I suspect these, insecticides aren't really commonly used anymore, but just being careful with your topical ivermectins and such. And then cats, probably most people do know about this one. So methimazole for treatment of hypothyroidism can cause really quite intense face, head, neck, and pinal self-trauma. So they become really, really pruritic and they can rip themselves apart. This was a case I did see. I think a GP vet at the place that I was working at sort of passed me in the hallway one day and said, "What do you think about this?" And I was like, "Oh gosh, I don't know." Then it transpired that the cat was on methimazole, and so we weaned it off slowly, started another treatment for hypothyroidism, and then no problems again. But something that sounds obvious, but to keep in the back of your mind, I guess, if you've just started a hypothyroid cat on this. And then lastly, something else we've probably always got in the back of our minds when a Doberman walks through the door, or Anna's probably got lots of things on her mind about Dobermans.
A lot.
But avoiding TMS, and the main reason as a dermatologist, I guess, would be vasculitis or vasculopathies that TMS or sulfonamides in general, I think, can induce in these dogs. And then again, to diagnose a drug reaction is quite challenging. There's no specific test. It's often a combination of a lot of different things. So, you know, a good history, what does the dog look like? You can do histopath, but it's really only useful for those specific syndromes, like we said before, Sweets, Wells, EM, that kind of thing, not so much for drug reaction. Prior exposure to the drug. So this was interesting. In humans, there's some thought about whether a human can have a drug and be completely fine, and the drug does its job and they finish the course, and then the human requires the same drug again, and that's when the drug reaction occurs. And it's that whole sensitization process or loss of tolerance at an immunological level, which is quite interesting. Again, we don't know enough about this in dogs. And this kind of leads me into the next point, where when you withdraw the drug, often the clinical signs will resolve completely within 1 to 2 weeks. And then that's sort of another diagnostic clue that the animal resolves when you pull the drug away, but then the clinical signs relapse if you start it again. And that's a bit of a problem from an ethical standpoint. I certainly wouldn't let any vet restart a drug that potentially induced a reaction in my dog. So we don't really do that in our veterinary patients, but in people, that's sort of another diagnostic test you could do. So treatment.
It's tricky. There are conditions where there's not really an alternative as well. So if, like, for example, there was an autoimmune disease and you started an immunosuppressive medication or something like that, and like, yeah, I can imagine, okay, let's just give it one more go and see.
Totally. I think it obviously comes down to the dog and the owner and the vet relationship, deciding what's best. But yeah, it's tricky. So treatment, withdraw all drugs as soon as possible, topicals, shampoos, find out when the dog was last vaccinated. We go really extreme and withdraw fish oils, you know, any kind of supplements, nutraceuticals, arthritis support, everything gets removed for 2 weeks, and supportive care. So, you know, cleaning wounds, saline only, nothing else, analgesia as required. You don't really want to use oral antibiotics for obvious reasons. And then pentoxifylline or Trental, so helping to improve blood flow to those distal extremities if you do have a vasculopathy. May or may not be useful, but we tend to try it at higher doses 3 times a day, and it doesn't usually cause any harm. Pentoxy is not commonly a drug associated with drug reactions. And that's it. So I just wanted to mention again, in the previous lecture, I sort of focused, in the interest of time, mainly on our Cushing's cases, our hypothyroid cases, and I don't think we had time to go into alopecia X and other sex hormone disorders, but again, more than happy to later on if people are keen. And then systemic lupus is another cool one, hepatocutaneous syndrome, Sweet syndrome, and Wells and EM is probably a lecture by themselves. And then there's also paraneoplastic pemphigus. There's probably more, but just started with a few today.
Always more. I actually had a hepatocutaneous syndrome yesterday, second one of my career.
Wow.
I know.
What breed was it?
It was a Shih Tzu cross.
Oh.
And it had really distinctive liver changes on ultrasound, like really well demarcated hypoechoic nodules right throughout the liver. And then I look back through the history, it was like, bacterial pododermatitis. And it was quite an unwell dog. And when I looked at its paws, they were like really crusty and nasty.
Cool.
Yeah.
Not cool for the dog. Very sad.
Not cool for the dog. No, our older dog though, and as far as kind of, you know, a lot of management changes we could make in terms of how he was being managed. So they're going to do some ups, get a definitive diagnosis, and then hopefully get him on some management changes. So hepatocutaneous syndrome is associated with an amino acid deficiency and correction.
Yes.
This is very much an overlap of our specialties. And they tend to be amino acid uric, and they're losing amino acids in their urine as the etiopathogenesis. But then in humans, it's really closely associated with glucagonoma, but not so much in dogs. So there's a few different sort of etiologies or etiopathogenesis, but essentially you get this combination of really sort of crusty skin lesions and secondary bacterial infections or malassezia, I imagine, in the pores, with these really kind of distinctive nodular changes in the liver.
Yeah, exactly. And then I think, at least in the States, they do offer intravenous. Yeah, exactly. Intravenous amino acids. It's super expensive, but it so far from what I've read has had a really great outcome. I think they need about 3 doses, don't quote me on this, but 7 to 10 days apart, and then follow-ups every 3 to 6 months or something as needed.
Yeah.
But I think to date, that's probably the most effective treatment. Do we offer that anywhere?
Yeah,
in Australia or
yeah. The trouble with amino acid infusions is it's quite irritant for the, like we get phlebitis, so typically they're delivered via a central line. There are formulations and concentrations you can use peripherally, but they're not as concentrated and therefore they need more infusions. So it can be difficult to manage, but in theory, I mean, we can do parenteral nutrition. So, and you just buy the amino acids, the lipids, and the other component. Carbohydrates, sorry. You can just buy the amino acids. That probably is what I'm getting at. So we can absolutely do that. But then there's actually a paper came out in JVM recently with a really nice like kind of picture of how to manage fatty cutaneous syndrome, and whole food diet is recommended. Processed food is one of the causal and one of the factors that's associated with poorer outcome. So switching to a whole food diet for whatever reason, I don't really know why, is indicated. I looked this up yesterday. That's why I know.
Yeah, cool. I actually do have a recipe that someone in America sent me.
Oh, cool.
Yeah, one of my mentors for a whole food sort of HCS diet, I guess. I've never had a patient to be able to try it on, but there probably is a market for it, again, for dogs who aren't compliant for amino acid infusions or just from a cost perspective. So that's really cool.
They're actually quite sick dogs.
Yeah.
Aren't they? So they're often off their food. Like it is actually hard to get them to eat like a processed, manufactured hepatic diet with like,
especially like a white fluffy cross. If you had like, a Staffy or a pug, it might be better.
Well, I've asked them to send me through the biopsy results when they come through, but we might collaborate on that one.
Cool.
Yeah.
Awesome.
And then the other question I had, sweets and wells, are they humans in human terms, or have I just completely
yes. Yeah.
So
again, there's lots of controversy about the classification of those diseases, but Stevens-Johnson syndrome is the human, sort of more accepted human term for sweets, or sterile neutrophilic dermatitis. So we refer to that in dogs as well. And then wells is associated with eosinophils, so eosinophilic dermatitis. And then you also get not only the cutaneous signs, which is a really, really pronounced erythroderma, alopecia, sort of skin sloughing. The poor dogs also come in with really awful diarrhea, like parvo diarrhea, vomiting.
Then quite acute onset?
Yes, can be. Yeah.
Okay.
Yeah, like I saw one case of wells. I had seen the dog was unwell maybe over 48 hours. And by then it was really unwell. And the skin seemed to progress quite quickly too. This particular dog, I can't quite remember, Staffy Cross or something like that. I remember the owner showed us a photo on his phone of literally a day or two before, and it sort of just looked like it had maybe a hotspot. And then it had progressed to full on, painful sloughing by the time it had come in, and actually came into ECC. Then derm got involved. So yeah, they're really nasty diseases, treatable, but I've got some cool photos of a sweets case as well. Actually, the whole dog, like face, limbs, body, especially frictional sort of axilla groin, just sloughing off. It was horrible.
Associated with systemic eosinophilia?
Yes, on bloods often they will have that. Yeah. but not always.
And cats, do cats get it? Because they get like
Mm,
hypereosinophilic syndromes.
yeah, that would be tricky in a cat to diagnose because eosinophils just come to the party with any kind of skin inflammation, don't they? So, like I guess if you biopsied an allergic cat, it would have eosinophilic dermatitis everywhere.
Yeah.
But I guess I'm not sure if cats actually get wells, but it would be clinically much worse looking than an allergic cat, even the worst allergic cat, because you just don't see the skin slough.
Yeah.
But I believe it's more of a canine syndrome. I don't think it's been reported in cats.
Yeah, okay.
Could be wrong. We'll have to check.
Yeah.
Yeah.
And then the only other thing that I've actually seen derm presentation, which might be worth a mention, is neosporosis in dogs. And toxo in cats. I've never seen it manifesting as toxo in cats. Used to be more myositis, pancreatitis, hepatitis, pneumonitis kind of thing, and neuro. But when they've got systemic, like overt toxoplasmosis. But I've had a couple of dogs that we've immunosuppressed for other reasons, like IMTP, IMHA, or had one dog with eosinophilic pleocytosis, presumed lungworm in the central nervous system.
Wow.
So those dogs were immunosuppressed, and then they developed this systemic like illness, like pyrexia, hepatitis on bloods, that will biochemical hepatopathy on bloods, myositis on bloods as well, muscle pain, and a pretty profound CK elevation. And they get these, like, I'm going to use the wrong words, macules, maybe.
Maybe.
The like huge, like, I guess pustules, maybe. They rupture.
Bulla.
Oh, okay.
Admittedly, I've not actually seen a case of neosporosis, but I think what you're describing would be more a bulla that sort of turns into an ulcer if they're rupturing.
Yes, it would be like quite ulcerative, but focal,
Right.
like they kind of swell up, like this red kind of not plaquey sort of lesion.
Blister, maybe.
Yes, that's a good word. Yeah.
Okay.
Yes, and we like found Neospora organisms in the skin biopsies. Which
Wow.
was, pretty cool in one of the cases. And the other ones we got them to do a neuro PCR for Neospora on just plasma, and they found it. So it's interesting. If you've got an breast patient, it could be anything.
I did have a case of disseminated toxoplasma in a cat who was immunosuppressed for allergic dermatitis. Ended up not making it. It was all throughout the lungs. I actually published that as my case report. And so I am quite cautious now. Again, controversial, and lots of people have different opinions about it, but I'll often do my toxo titers before using cyclosporin and Apoquel in cats. Not so much pred, but depending on the lifestyle.
Interesting. I didn't realize it caused that much immunosuppression.
Normally dose dependent, but also obviously prior exposure, which is a whole nother thing with the titers. How much information do they actually give us? But I do like to have a baseline, and that's something I was sort of taught, and so I do that now as well myself. Yeah, and I think once you have one case that stays with you,
it really
changes how you practice.
Completely changes how you practice. It's so bad. I mean, we should be going off evidence, but I feel like the longer I work for, the more conservative I get in my recommendations. Let's just do nothing. Anyway, we should wrap up. Thank you so much, Alex. That was really good. Now I think I need a lecture on sweets and wells. And we might tap back in when we get to an endocrinology section again, just to talk about the derm manifestations of different endocrinopathies again, and what we can look out for to differentiate them based on clinical signs.
Awesome. Sounds good.
All right. If anybody wants Alex, we will be putting together some request forms on our website. Stay tuned. We'll let you know when she's available.